deed goes unpunished. We invited her back. She's spent part of the afternoon meeting with students interested in going to medical school and sharing all kinds of wonderful insights. So we are thrilled to have her back here at Roosevelt University. She is a board-certified pediatrician and pediatric hematologist, oncologist with clinical expertise and research efforts related to the blood-brain barrier and malignant glioma. Sociologists have counter-hegemonic discourse. So her clinical practice focuses on drug delivery of systemic agents for pediatric malignant brain tumor patients. And she's passionate about ending structural racism and creating equity in healthcare and other realms. So she will be moderating the panel today. And then the panelists include Maureen Benjamins, who is a senior research fellow at Sinai Urban Health Institute, and she directs the Sinai Population Health Institute, an interprofessional institute focused on health equity and social determinants of health. The next panelist, Yu Lee, is an assistant professor of psychology here at Roosevelt University. She is a researcher, professor, and licensed clinical psychologist, and she focuses on experiences of oppression, feminist and liberation psychology, vocational issues, and the process and outcome of psychotherapy. And I just got to meet her, and I'm so excited. Our next panelist is Sharmila Mahmoodar. She is the Executive Vice President of Policy, Programs, and Research at Women Employed. She oversees Women Employed's policy programs and research and works on closing the wealth gap at the intersection of race and gender by growing women's economic power. Our fourth panelist is Amy Whitaker. She is the Chief Medical Officer at Planned Parenthood of Illinois and Clinical Associate Professor at the University of Chicago Pritzker School of Medicine. And she's been involved in Planned Parenthood as a volunteer, healthcare assistant, and physician for over 20 years. So I would invite our moderator and panelists to the stage, and I'm going to turn the mic over to Dr. Jackson.
Thank you. Thank you all for joining us. Okay, so we are here on this great occasion to talk about women's health and women equity and this symposium, and I'm so fortunate to be able to serve as a moderator for this great group of leaders that happen to also be women. And just to kick things off, just starting with Amy, can I ask you a little bit about your work and your organization, and then can you talk about the importance of women's health equity in the context of your work and your organization, please?
Now I can. Thank you. I'm thrilled to be here. I work at Planned Parenthood. It is my dream job as Chief Medical Officer. I get to both be involved in senior leadership activities and making important decisions and being at the table, but then I also get to do clinical care, which is my true passion in the universe. If you just ask me what I do, I just usually just say I'm an abortion doctor, and that's what I love to do. And Planned Parenthood in general and Planned Parenthood of Illinois in general, I think that when we talk about healthcare that is aimed at gender equity, like that's just what we do. I mean, that is our role and our passion. And so we're an organization that sees thousands of patients every year, and about 10% are men. So I know that sometimes really surprises people, like you see men. We do. We see about 10% of our patients are cisgendered men, but that means 90% of our patients are cisgendered women, and trans men and women, gender non-binary and gender non-conforming patients. And as such, it really does make our work all about gender equity healthcare. And the reason you have to have an organization that really focuses on women's healthcare and healthcare for gender non-binary people is because you can't often find it in sort of mainline healthcare. FQHCs, federally qualified health centers, they're not allowed to provide abortion care. And for a long time, they have not been providing gender-affirming care as well. And so for me, when I think about any kind of equity in healthcare, I think about intentionality. So you have to be intentional. You have to look at, like, where's the problem? Where are the inequalities in healthcare? And how can we address those? And it's never just, well, we make it available to everybody, so therefore it's equal, right? I mean, everybody's got access because we do everything and we make it available to everybody. That's simply not how America works. And so you have to be very intentional in order to have an organization to provide health care in an equitable manner. And again, I would say that it is one of the great joys of my work to be in an organization where we really do strive to, I'm not saying we do it perfectly every time, sometimes we try and we learn, but do everything with a health equity lens. So if we are thinking about where are we going to open up a new health center, what services are we gonna provide, it is generally goes through a lot of different machinations, of course, but one of them is always health equity in general and specifically women's and gender-specific health equity.
Thank you. And Yue, can you tell us about your work, your organization, and the importance of women's health equity in the context of that?
Yeah, thank you so much. I'm really glad to be here. My name is Yue Li. I am in psychology department at Roosevelt University. So in my clinical practice and teaching, I focus on feminist theory and psychotherapy, liberation and decolonizing perspectives. And that is really grounded in my training in multicultural counseling, social justice. I've had the privilege to work with clients from a variety of underrepresented backgrounds. I also worked with political refugees on my doctoral internship. So I'm really excited to bring that experience and teaching to Roosevelt students who are very diverse and committed to serving marginalized community in a mental health capacity as well. So I want to talk a little bit about the importance of women's health equity in a mental health lens. And I'm thinking women's health is important simply because of the fact that women are human and constitute about half of the world's population. And you may feel like, wow, why do you even have to say that? And the reason why I have to say that is because equity has not been achieved, certainly in the health realm and as well as in the mental health area as well. So I want to provide a little bit of a context in the mental health area, kind of taking us back into history. I would say that modern mental health treatment is built on the study of women, and only about 120, 50 years ago. So it's only recent that we pay attention to mental health, and that knowledge is very much built on the study of women from the 1890s when Freud studied quote unquote hysterical women. And now that term is obsolete, which led him to the conclusion that hysteria was rooted in sexual childhood abuse initially. However, his conclusion was challenged by other pristine colleagues and medical doctors at the time in Europe, because if his conclusion that hysteria was rooted from sexual childhood abuse. And given hysteria, quote unquote, was so common at the time among young women across all levels of society, that would mean that sexual trauma in childhood in particular was prevalent, and that was not a reality that the establishment or bourgeois class can accept. So they had huge pushback, and Freud actually changed his stance on his theory and reverted to perhaps I was wrong about that, and went into a different direction. So taking a look at that history, I think reminds us of how our understanding and acknowledgement of women's suffering under patriarchy has been long ignored, and we are just at the beginning of even acknowledging that and also seeing the impact of thousands of years of abuse, honestly, economically, physically, bodily, mentally, and spiritually on women. So I always go back to the Combahee River Collective, which was a statement that was made by a group of Black feminist women in 1977. They talk about, we reject pedestals, queenhood, walking 10 paces behind. To be recognized as human and evenly human is enough, pointing out the fact that we haven't been treated as so for many long time. And they also said if Black women were free, it would mean that everyone else would have to be free, since our freedom would necessitate the destruction of all the systems of oppression. So this idea that feminism or women's equity is, of course, about women first and foremost, but not only that, but connecting systems of oppression to our health, physically as well as mentally. So that's something that I'm passionate about. I'm very glad to be here.
Thank you so much for sharing. I just feel like I just want to go like this from all the historical lens that you just provided, Yue, so thank you very much. Going along the aspect of numbers and historical lens, as an epidemiologist, Maureen, can you weigh in on your role, your passion, your work, your organization as it relates to women's health equity?
Of course. Hi, I'm Maureen Benjamins. I'm an epidemiologist. A social epidemiologist, which means I study the spread of disease across population, but in particular, I study social factors that influence that. Unlike a lot of this esteemed panel, I don't study gender equity. I study racial and ethnic equity, but so I'll approach these questions kind of from that broader lens with understanding, as Yue said, this kind of systems of oppression and understanding the intersectionality of being female and being from a community of color, and how those different systems kind of compound to create different inequities. I'm at the Sinai Urban Health Institute, and that's a research center, part of Sinai Chicago. Sinai is the largest safety net system in Illinois, and we are a pretty unique research center because most safety net systems just don't have the money for a research center. But we've been around for over 20 years, and our mission for those 20 years has been to eliminate inequities. So that's what we do. We are really focused on any population that's been historically disinvested or marginalized. So we focus a lot on our communities on the west and southwest sides of the city, but trying to bring everybody to equity, which is, in my mind, it's giving everybody equal opportunity to achieve their optimal level of health and well-being. So that's what I'll be talking about today. Some of our work in particular, we've been studying how inequities vary across the biggest cities in the US. So looking at why is there, so not just this inequity between males and females, but inequities within the group of women in the US. So why do some women have a really long life expectancy and others have a shorter life expectancy? And not only that, but why is this gap between, in particular, the Black and white population, why is it really big in some cities, like our own, and much smaller in other cities? There's barely a gap in some cities in the US. So thinking about the structural factors, because race is a social construct. So what is it about the environments in different areas that lead to different health outcomes for different groups?
Thank you so much. And Sharmili, can you tell us, as an advocate, as a social worker, your work and your love and your passion around women's health equity?
Yeah, thank you. And I'm so glad to be here and so excited for this conversation. For the past 50 years, Women Employed has relentlessly pursued equity for women in the workforce. And it's been focused on growing the economic power of women, as you heard, and creating workplaces where women can truly thrive. You might hear that and wonder if I'm in the right room. I assure you that I am, because we don't believe that you can separate economic equity from health equity, particularly in the US, where our health and wellness is truly predicated on our economic well-being and vice versa. Women continue to, as you've already heard, face significant barriers to equity, but particularly economic equity and justice. We continue to be negatively impacted by persistent pay gaps. Many of you may have heard, March 14th was Equal Pay Day. And a lot of what we were hearing about in the headlines was how little progress has been made over the past 40, 50 years, where the pay gap has at best closed by pennies. We also disproportionately shoulder the responsibilities of caregiving. And doing so often results in us having lost wages and long-term career impacts. We are still experiencing sexual harassment and assault at alarming rates, and that has also led many of us to leave jobs to secure physical and mental health and safety. And the vast majority of us do not have access to workplace supports like paid family and medical leave, which most of the rest of the world enjoys. It negatively impacts our ability not only to care for our own health, but our ability to care for the health of those we love. And due to the intersection of gender and racial bias, of course, all of these disparities and barriers are simply amplified for Black and brown women, but also for women who are gender minorities, women who are immigrants, et cetera. So I'm looking forward to the rest of the conversation, but that's a little bit about where I and we are coming from.
Thank you so much. So as you've just touched base on, Sharmili, there's all these intersectionalities of being a woman. And so for myself, I'm a mother, and I'm a wife, and I'm a physician, and I'm a scientist, and I'm so much more. And I'm just one person, and so people, ask questions of me as a Black woman as well. Knowing that as women, we have so many different intersectionalities. Yue, can you explain for us, what does it mean to be a woman, and how does that affect our overall health, especially for the men in the room?
Yeah, I would happy to kind of think about and deconstruct the concept of gender for us a little bit, just as Maureen was talking about race is a social construct. Similarly, gender is also a social construct, different from biological sex. So I have a little fun prompt interactive question for the audience, which is what I ask students to reflect on and even write about when I teach feminist psychotherapy. So when we think about gender, it is much more beyond the presence of how we look like: hair, facial features, body shape, physical, observable things. It is actually socially constructed in every part of not only our life, but our body, our emotions, and our soul, in fact. So I like to ask all of you to reflect on a couple of questions. Number one, this is for both all genders presented in this room to reflect on your personal experience. What is your earliest memory of a gendered message? Meaning a message that make us realize, oh, I'm a girl or I'm a boy, typically. Number two, how did you learn to behave like a man or a woman? Number three, how has being a woman or man influenced your decisions on your major, future career paths, and other life decisions? And number four, what are some values associated with being a man or a woman and that are taught to you, maybe by your family, your community. So I know I gave you just a lot of time to reflect on that, so I'm looking for perfect answers. So for the women who are present, I'd like you to just shout out a couple of words. When you think about the idea of being a woman, what are some of the adjectives, maybe expectations or values that either was taught to you or you perceive as an expectation imposed upon you? Just a couple of examples. Can I have? Vanity? Oh, wow, that's a great one. Vanity. Yeah.
I have to say organized. I feel like every woman I have met is
Yes.
organized, and I associate that with a female trait.
Yeah, you gotta be all the roles you play, right? You have to, keep it under control. Yeah.
Can't walk alone at night.
Oh, can't walk alone at night. Absolutely. Yeah. Domestication. Oh, yes. Politeness, absolutely. Or dare I say sweetness and smile and be nice. Yes. Caretaking, absolutely. Yeah. Thank you all for that participation and interaction. So we can see, just to dig a little bit, we can see a lot of how we have been taught, and these messages impact us. Again, our life, our body, it gets into our head in terms of our thinking process and our soul and how we carry ourselves as well. So how does gender affect us in different areas of our life? I like to break it down to different levels. There's the core, which is individual level, and then there's the interpersonal, how we relate to each other, and there's the institutional, systemic, the contextual and maybe historic part. So individually, several things affect us. Beauty standards, vanity, right? We can't be too, we have to be a very specific type in terms of our body. And of course, that's based on Eurocentric values of beauty, which has all sorts of constrictions and harm in terms of not being able to accept who we are, how we look like, especially we're not white. Or fit into that body type. And how does intersectionality come into play in that? We are all taught how to be a woman or our specific gender based on our own family. That comes from culture, and that comes from the communities and maybe education, places of worship. So I'm Chinese in a traditional Chinese sense. Some of the messages that I got growing up is a woman's value is to be a virtuous wife and caring mother, and noting occupation and profession is not prized. Identities for women, I need to be gentle, I need to be unassuming and tolerant, and you may all have your versions of that so my experience may be different from someone who's from Southeast Asian family versus a Muslim family versus a Black family versus a Native American family. So we all have our own versions, but there are some common themes in that. And interpersonally, that a lot of the teachings of gender teaches us to be caring towards others, to put our needs, others' needs before ourselves. And that, of course, affects our health and the way we treat ourselves and prioritize self-care as well. And institutionally, I want to hear my fellow panelists talking about gender wage gap and lack of health equity, things like that. So I'll just briefly touch on the behavioral and mental health outcome. How does all of that messaging, teaching, conditioning from family, school, society, media, Instagram, Twitter, TikTok, right? How does that affect all of us? In my clinical work and research, I see women disproportionately experience self-doubt, feeling like I have nothing important, valuable to say. I really struggle to speak up, struggle with setting boundaries, taking up space in groups, assuming leadership positions, advocate for ourselves, and prioritize self-care, and also really avoid conflict. And that as you can imagine, lead to all sorts of struggles. It could come up as anxiety, depression, interpersonal struggles, and burnout due to the emotional labor we're carrying and also the lack of self-care. And all of that constitute a larger gender-based traumatic experience. So this is kind of a little bit of the question of how does being a woman affect our health, and I go back to the message. It's all-encompassing, right? Mind, body, soul. This is what it means to be oppressed.
Thank you. That was so, that was a lot, and I appreciate it. Thank you. Thank you so much, and incorporating everyone else in this room. So just, again, thinking about the intersectionality as it relates to a woman and race and socioeconomic, I would love to hear from Sharmili and Maureen to touch base on those aspects as it relates to women's health.
So work is a social determinant of health, right? So it shapes our ability to be safe and healthy. And the reality is that while work is not the only aspect of our economic lives, most adults spend at least half of our waking hours at work, right? So making work, means work is such a significant piece of our living environment on a day-to-day basis, and it influences your health. So where you work can determine how you are exposed to a number of different things. So for example, you can be exposed to different things physically. You might be exposed to different chemicals. You might be exposed to noises, to vibrations, to sunlight or lack thereof, right? You can also be exposed to a lot psychologically. So stress, hostility, navigating workplace relationships. You are also, based on work, it is going to determine how and where you live. And where people live determines their exposure to things like the physical environment. Like, do you have green space around you? Or are you exposed to environmental pollution? Which again, definitely intersects with socioeconomics and race as well. There's your social environment. So what are your opportunities to network and connect to others? What kind of transportation access do you have? What's your exposure to violence? Do you have access to things like social services? Your health access, like, do you have a clinic near you? Is it far away? What kind of specialties can you get? How quickly can you schedule a mammogram, right? Like all of these things are pieces of it. So thinking about who gets to work where and what the quality is of those jobs that they work in is critical to having any conversations about health. So Women Employed collaborated not too long ago with the City of Chicago, World Business Chicago, Civic Consulting Alliance to put together a report on what the economic impacts of COVID-19 had been on women in the city. And I'm sure it's not going to be shocking to any of you to know that things weren't so great to begin with, right? So the status quo that was then impacted by the pandemic was not one that was like working particularly well, particularly for those who were the most marginalized, right? And the most under-resourced in our society. And so one of the things we were able to show is, again, shocker, women of color are overrepresented in low quality and low paid work. Their work often requires more manual labor and so has particular physical impacts, also psychological stressors, and are much less stable jobs and jobs in which they have less control, right? This is, you may have heard, occupational segregation, right? Women are overrepresented in low quality work and underrepresented in high quality work. But I think it's helpful to not just think about the socioeconomic factors in that and thinking about race and ethnicity, but also how we think about what the arenas for solutions are. So we tend to approach, at Women Employed, we tend to approach advocating for women's economic equity by looking at policy, practice, and culture. So asking ourselves, like, what policies do we need to put in place? Legislative policies, yes, but also systems, administrative policies, workplace policies. Not everything can be legislated nor should be legislated, right? How do we make sure that when the policies are put in place, they're actually followed, they're actually implemented, and that people actually get the full force of what it is intended to do. How do we also make the cultural and narrative shifts that are necessary to ensure that those policies and practices are truly integrated, right? It shouldn't be about who's leading an organization. It should be so embedded in the culture of the organization that we value people's health, for example, that we value their well-being, that regardless of who the leader is of the organization, those values are ones that the people who are working in that organization, no matter at what level, can rely on. And then what do we see, like, and this is building off of your, what you were sharing about kind of the concept of being a woman. What do we see as the role of low-income women of color in our society? And how do we support their right to health and wellness, right? So I think that it's, as I said before, it's very intricately woven, these issues of health and well-being and work. And when I say work, I should also point out, women do a lot of work that is unpaid. So when we talk about work, we're talking about work as both compensated financially and uncompensated. So when you said organized, right? Like women are organized, you all have heard, right, about the emotional and mental labor that women are also often putting into their households or are asked to carry at the workplace as well. So that's how I think they're integrated. Absolutely.
Yeah, you did a great job and covered a lot of it. I'll just add a few other ways to look at it. In research, we like to use conceptual models. And so there's some great ones. The World Health Organization has a great one of social determinants of health, and it encompasses everything that Sharmila just talked about. And it seems like in our society, we focus on the most proximal causes, the causes. So if you're looking at, say, death, that's what I study. That goes over really well at parties, right? But I study mortality, and if you say, why are mortality rates so high in this certain group of people, the first thing people think about is what? Their behaviors or their access to health care. Those are the proximal, the downstream factors. And what she's talking about and what we're always pushing is to just keep going upstream. So why does somebody have that behavior? Is it because their environment? Is it their social environment? Is it the institutions that they live within, work within, study within? And why are those like that? Is it the policies? And then is it the culture and the norms and the social, the isms, right? Is it racism, classism, sexism? What is putting the force on those policies or regulations that then filters down to individual behaviors? So one thing I study is breast cancer mortality. So we found that at one point in time, the black mortality rate from breast cancer in Chicago women was twice as high as the white rate. And the question is, why is this? And so a lot of people would think, well, let's educate the black women about mammograms. Well, that's a nice thing to do, right? It's important. Education's really important. But that's not going to make the difference, right? So when we looked into it, it's not only there's not access to mammograms, there's not funding for mammograms. The mammograms at the time in our own hospital, they weren't digital. They were in the wealthier communities, but not at Sinai. We didn't have the money. We're a safety net system. Now we have the money. We have digital mammography. But back then, even if you could access it, it was a lower quality in certain neighborhoods compared to others. So when we published this study, it forced people, it forced their hand. So we had this big Metropolitan Chicago Breast Cancer Task Force, and they convened all the experts, and they said, what should we do? So they pushed forward some policy issues, a quality reporting guideline for all local hospitals so that everybody could compare and everybody could look at, so funders could know, where should we put our money? They found they should put their money into better mammography services at Sinai. And that helps. So then the quality evened out over the city. And then they pushed, what should we be funding? We should get our legislation to require, put more money into screening so people who don't have insurance can actually get the exam they need for the referral to get the mammography appointments and the follow-up and whatever they need. So it was coming from on top, and it helped push that along. So now the black-white gap in Chicago is a lot smaller, and it's because we had the data and people understood that you couldn't just go to those individual level behaviors and expect to see these group level differences.
Thank you so much. And just thinking about and talking about access to care, I want to get Amy's take, and we're going to get into it, the Dobbs decision, and what ramifications that decision had on you as a leader within Planned Parenthood and around everything else to really be able to impact and help these new restrictions around reproductive health and abortion for women.
Yeah, let's get right to Dobbs. What effect it has the Dobbs decision is the decision in June that overturned Roe v. Wade, allowing multiple states across the country to make abortion illegal, which they have quickly run to do. And so how the decision has affected us, I mean, it permeates everything we do. I mean, there's not a day that goes by where we're not doing something to deal with the repercussions of the Dobbs decision. I will say that to put it in context, we knew this decision was coming. I started working at Planned Parenthood full-time in 2016, about 5 weeks before the 2016 election, so it was a little bit different job than I thought I was going to have. But we've been preparing for it as we watch the Supreme Court become more and more conservative. We knew that this decision was coming, so we have been really preparing for years for the Dobbs decision. And never have I wanted to be proved wrong as much as I did on that one, but sad to say, I was not proved wrong. And we've seen it immediately. And even in 2021, when Texas was able to keep their law on the books which outlawed abortion before or after 6 weeks, we saw patients from Texas 2 days later. And since the Dobbs decision, we had about 5% of our abortion patients were coming from out of state, and just within a couple of weeks, it is now up to 30%. So it used to be on a clinical day, if you met someone who had come from far away, you're like, oh, wow, I can't believe you had to travel so far. And now, just on Tuesday and yesterday I was in the clinic. I mean, I saw patients from Tennessee, I saw patients from Texas, I saw a patient from Georgia. It's every single day that we're seeing patients who are forced to travel far to get here. So in preparing for it, we have been opening clinics. So since in the past, say 3-4 years, we opened 2 new health centers, and we did it based, again, very intentional. We did the research. We figured out where in Illinois is there the most need for patients in Illinois, because we don't know really for sure what's going to happen in the future. And then once we'd done that research, we said, okay, then where in that spot can we open a clinic that's also easy to get to for out of state? So we opened a clinic in Waukegan, we opened a clinic in Flossmoor, we expanded our services in our Champaign Health Center, which is about an hour from Indiana. And then we've also invested in improving and making sure that we have access at all of our health centers. So we have 17 health centers around the state of Illinois and a growing telehealth service. And all 17 health centers now provide medication abortion. And all 17 health centers and telehealth provide gender-affirming hormone therapy. And so we've worked really hard to say it doesn't matter where you are in the state of Illinois, if there's a Planned Parenthood health center near you, you can get these services. And now 7 of our 17 brick and mortar health centers provide procedural abortion. And we are looking to see if we need to expand that as well. And all of these decisions, again, when we make them, we say, what can we do? We can't just offer new services. We have to make sure that we're implementing them in a way that results in equitable health care. And so we also started prenatal health services just as a bridge to care. So we don't have right now the resources or the bandwidth to provide the full range of prenatal care. But we wanted to start providing bridges because it can actually take a really long time for somebody to get established into care, especially low-income women, especially Black women. And so we were not able to do it everywhere, but we're doing it at Roseland and Englewood because Black women have 3 times as much likelihood to die because of maternal mortality related events than white women in this country. And so if we just said, okay, well, where's the most convenient spot for us to provide this bridges to prenatal care? We might say downtown or our giant near North Health Center, Aurora, but we really wanted to focus on Englewood and Roseland where we know those patients are having the hardest time getting into care. And along those lines, too, I would be remiss if I didn't talk about the inequities that the Dobbs decision has resulted in. So when we think about patients having to travel for care, it really falls heaviest on our marginalized patients, who are already struggling to get health care, patients who do not have flexible jobs, who cannot just say, hey, I'm gonna take a couple days off and travel up to Chicago and have my abortion. These are patients who are struggling on the margins of work and home and health, and then they're forced to make these long drives. So we've also really had to expand our navigation services. And so a year ago, we had 1 navigator, and now we have 4. And we'll probably hire a 5th in the next year just to help patients. Think about it. You have to drive here. You have to get childcare back home. A lot of people don't have access to that. Then you have to find a place to stay. And when the Dobbs decision first went down, we were hearing stories of women who were sleeping in their cars outside of the health center. And we, as an organization, made a commitment to nobody who is coming to our health center. And I should say all of our partners in providing reproductive health care are the same way. So I don't want to say like we're better. No, we're working with our partner organizations to say nobody who comes to Illinois for health care has to sleep in their car. And now we're seeing this spill over into gender-affirming hormone therapy. And so, so that's it. That's how the Dobbs decision has affected us.
That's it?
Yeah, just a little bit.
Can I just ask a follow-up question to that? Have you seen, either within Planned Parenthood or your sister organizations, that there's more mobile health clinics to help address these inequities? And if so, why or why not?
So we thought about whether or not we wanted to do a mobile health unit, and one of our sister affiliates has done one, but there are a lot of barriers to that. So they've been really struggling with where can we park our mobile unit, and where can we do so in a safe way. When you think about abortion care in particular, there's a lot of security issues that come with it. So I'm very much hoping that the mobile unit that our sister affiliate has put into place ends up being successful. But at this point, we're saying, okay, great, we thought about that, you're doing it. Let's see if we can learn important lessons from you to make it work, and then we can move forward with that.
Thank you. So just thinking in the context of this Dobbs decision, these are rather short-term outcomes that we've seen come about on women's health equity. Maureen, can you touch base on long-term effects of the fact that there's these inequities in health for females, as well as those who are underrepresented women, as well as just other, the dichotomy or the intersectionality of women and women's health care? Just long-term effects of the fact that there's this lack of equity.
Yeah, sure. And I think, to be clear, there's a lot of inequity in the research world as well. So the NIH disproportionately funds research on diseases that affect males. So women's diseases are under-researched. The same is true, right, for across different types of inequities. So the Black researchers are funded at a lower level than white researchers at NIH. They're less likely to be in positions of power across academia, partly because of all the roles that we've talked about and the other jobs that they have outside of the classroom or outside of their labs. So there's really kind of this burden on these populations from the beginning. And if you don't have representation at all levels, you're not going to be studied. And if you're not, it's what we measure matters, that kind of idea. So then we don't know as much about female disorders and diseases. And just as one example, we have a study coming out soon about the life expectancy gap in Chicago and what diseases contribute most to that gap in life expectancy. And we compared males and females. And do you know what is the #1 cause for men? What's leading to this black-white gap? Most people guess it's violence. But for women, it is not. So if you just look at everybody combined, we have a lot of resources going to violence prevention in the city. But for women, the #1 disease leading to the gap between black and white women is heart disease. That gets a lot less attention, right? Heart disease and cancer, the 2 biggest killers. But that's where we should be funneling our efforts and funneling them to the preventive side, to the upstream factors. But if you don't study males and females separately, you're not going to know this. So a lot of the numbers that we look at, they just hide. If we look at US numbers, they hide what's going on between males and females, between the different communities of color. If you look at Chicago, it hides what's going on between our community areas, pointed out by some others talking about neighborhoods that need more assistance in accessing resources, accessing healthcare. So we just want to make sure that all of our efforts, we are pointing them to each group, and particularly the groups that have been historically disinvested at higher rates than other groups. So that means pointing at women of color. It was mentioned the maternal mortality. It went up 40% in the last year. Well, the last year we have data. So in 2021, the maternal mortality rate in the US went up 40%. And our rate is about 10 times higher than our peer countries. Nobody else has rates like this. So there's obviously some clear indications in the data, but we're not getting, you may not have heard about that, right? It's not huge in the media as some of the other issues that affect males or affect the whole population. So to answer your question, that we need the data, we need it specifically for different groups, we need it at local levels.
So that leads right into my next question for Shamili in thinking about research disparity. You just outlined for us, Maureen, that it's prevalent in various different aspects of women's health. And we've talked about emotional and mental health and how important that is, and physical health, and the research aspect of it. But can you please touch on for us women's economic health and how that is all rolled into, and what your organization is doing to help with this financial toxicity and burden as females often see and have, and what is coming out of some of the talks and discussions around that?
Yeah, so I think one of the things that we often are advocating for is the disaggregation of data. So exactly what we were just talking about, that you cannot craft solutions without truly understanding the nature of the problem. And you can't do that if you are not looking at the disaggregation of data, not only by gender and not only by race, but by both at the same time. I think that's one of the things that we see a lot when we think about economic news. We'll hear about men, we'll hear about women, and then we might hear about Black communities or Black workers and white workers, but we're not really understanding what the needs are of Black women workers, for example. So much of our work is really about illuminating, articulating, and pointing out when that is not happening in terms of thinking about economics at the intersection of race and gender. So as I mentioned before, our work has really spanned a lot of different, we use a lot of different levers, I would say, to create change. So one of them is policy, and we do a lot of legislative work. And some of you may know that after 15 years of trying to get it passed, we were finally successful in getting passed into law paid time off for all working people in Illinois. Yes, it is absolutely something to celebrate. And it is horrifying that until that time, 1.5 million working Illinoisans did not have any time off that was paid to go to the doctor, to take care of their kids, to take a little bit of time off for any other reason at all. So it was a hard-fought victory, and it is so not enough. So we are currently working on, and I can talk about it a little bit more later, on paid family and medical leave. As I mentioned before, we are the only nation, only industrialized nation that does not offer paid family and medical leave. And when you are thinking about something like having a child, for example, it's just as important to be able to go to your prenatal visits as it is to bond with your child once they're born, right? And so having a couple of hours of sick time is just not going to cut it. And it is directly connected to things like maternal and child mortality as well. If we don't provide the ability for people to pay attention to what they have to in order to understand, in order to survive. I mean, sometimes we're talking about thriving and doing well. It's literally survival as well, and I think it's really important for us to remember that. Then we're really not shaping an economic society that values everyone's lives, let alone their contributions and other things. So we start with disaggregating data. We also push for policy change, but we also focus a great deal on the implementation of policy that has changed. So one of the things, for example, that we do is that Illinois is actually one of the most progressive states in the country around having equal pay laws, right? So the laws that ensure that you are paid equally to someone else who's doing very similar work at the similar place of work. But we recently did a survey and found that almost 80% of women across Illinois did not know what their equal pay rights were. Right? So we're working with the Illinois Department of Labor on making sure that that is something that changes, because those rights, if they're only on paper, are not particularly useful to any of us, right? They have to actually be exercised, implemented, enforced, kind of all of those things. And then we're also working on cultural change, and cultural change is very broad, right? But it's everything from helping employers understand that you have to actually ask people what they need and not assume it, in order to shape a workplace that truly supports the workers in it. We also do work on making sure that healthcare careers, for example, are more accessible to women, not only at those entry levels like CNA, but also the ability to get certificates and training that allow people to move up in these career pathways. And there are things that you have to pay for, like CPR training, like your uniforms, like clinical training. And all of that costs money, and it costs time, which costs money, which costs transportation, which costs money, right? So really making sure that we're doing everything we can to really close the leaking around those pipelines, right? That get people to access and well-being. And I'll share one more example, and that is in February of 2022, the American Heart Association had come out with a study showing that women who had experienced sexual harassment at work and or sexual assault were at significantly higher risk for developing long-term hypertension. And so when we hear about, like, for example, heart disease being a top reason for mortality among women, it's also critical now, right, knowing this from the American Heart Association, that we're asking questions about people's experiences of workplace sexual harassment in order to ask them the questions that will be able to target the interventions, right? So again, I think it's all about asking the questions and then targeting the answers.
Thank you. And as we talk about disparities, it makes me think about the whole women's suffrage movement and how it took so long for the U.S. to see that women needed to have the ability to vote just like males did. But in that context of women's suffrage, there was also another marginalized Black female community that still was not able to vote. Black males were not able to vote. So in thinking in that same disparity lens, so we think about equity, 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 but a lot of times other sub-marginalized groups are not taken into consideration. So in us here sitting on this panel and thinking about women's health equity and talking about the Dobbs decision, Amy, can you say how this decision and even the most recent decision by Florida and Iowa of not allowing or banning the gender-affirming abilities or medications and assignments, how this downstream effect is working towards this non-binary and non-binary transgender community? Sorry, I took you from law to politics to health.
So, you know, I touched on this earlier. I feel like the Dobbs decision in opening the door to making abortion illegal in states has really been somewhat, it's like a snowball effect. It's like, oh, wow, we can control sexuality and gender health through law. Great, let's start on gender-affirming hormone therapy now. And we've seen it. I mean, it's spreading all over the country. The more and more states are banning gender-affirming hormone therapy. And so anytime I'm talking about health equity and gender equity in particular, and we've worked really hard to stop using, gendered language when we talk about abortion care. So we say anybody who has a uterus can get pregnant. And so the care, sexual and reproductive health care and abortion care, I have done abortions for men who come in, and we call them Mr. and they have male voices, and they are trans men, and they have uteruses, and so they can get pregnant. And watching the gender-affirming hormone bans across the country has just made me realize more and more how much sort of gender equity is important, and how much we have to stay alert to these creeping inequities that happen. Like you said, a lot of people don't think about that. A lot of people, when they think about sexual and reproductive health care, they really just think about cisgendered women. So I'm glad to hear in this panel in particular the references to it. I did almost wear my t-shirt that said gender is a social construct, and that staying alert to these possibilities is really important. And then I'm just gonna tell a quick story, because when you ask how these things affect people, it's my job to be super optimistic. Oh, we're doing our best at Planned Parenthood. But the answer really is it's bad out there, right? And so it's really hard, and there are people who are falling through the cracks. And that is what's really most distressful about our current environment in terms of health equity. And I was just recently in my job at University of Chicago, ran into someone who isn't sort of caught up in this world, and he was like, oh, I've heard about that, but you guys are taking care of it, right? Those were his exact words. You guys are taking care of it, right? And I thought, do you really think we can just take care of it? And so it's really important to remember that these are going to have long-term repercussions for gender non-binary, for trans population, for cisgendered women, that we can't just take care of it when these policies are enacted. When abortion is illegal in other states, it's illegal. So there was a story recently about a mom who helped her daughter get an abortion, and she is now being prosecuted for that. And because she was in a state where abortion is illegal, and people were literally to me saying, well, I mean, how could they do that? I'm like, because it's illegal. You know what I mean? It's like this idea that people don't really get it. Could it really be illegal? So yeah, I'm trying to be optimistic, but actually it's really bad out there. And it's really hard. You can't make up for what's happening in those other states. We can do the best, and as you said, Illinois is a very progressive state, and we have wonderful laws on the books, and we just recently passed more that protect physicians and providers in this state, and that expanded economic access to care. But at the end of the day, when these things are happening, you cannot completely overcompensate for that. Sorry.
So I appreciate your authenticity, and in just thinking about our role as female and how Yue described in the beginning, kind of like what are some of the things or thoughts or behaviors around being a woman and what does that look like or what does that sound like. So I appreciate your honesty and authenticity in answering these questions, because it's not going to always be this sunshine, rainbows, and colorful flowers. And it's important for us to understand that as females, males, how we identify ourselves and how others identify themselves. But just coming back to you, Yue, in the fact that there's so many roles that females or women play as all these different aspects of themselves, what kind of toll does that have on our mental health and being able to help others around us? Can you touch base on that?
Yeah, thank you for that. I feel like some of what I'm talking about is gonna kind of really go along with Shamali, what you were just talking about, the workplace experiences and the roles that we play as women. I'm really glad that our panel really have a holistic perspective in connecting the isms that's very abstract out there, very large, and connecting it to something that is very personal. The personal is the political, right? In physical health, in mental health, and economic health, and thoughts and struggles that live with us, that we live with every day. So when we look at the inequity of the workplace, we see a lot of evidence still of inequity. For example, in our society, we can just imagine men still occupy roles that maintain social power. When we think about law enforcement, CEOs, politicians, medical doctors, predominantly men or white men, and women are seen as more suited for providing care, which presumably and incorrectly requires less knowledge and skills and should be paid less. And we can still see this pyramid in even Fortune 500 companies where the total breakdown of women and men employee in the organizations are about half and half. But if you go up the management chain, you will see there are 40% of the management positions were represented by women, 32% of board directors are women, and only 8.2% of the CEO positions are occupied by women. And you think about women of color, that obviously is only a sliver of the general population of who are in power. And we also see intersectionality in terms of the equity, going a little bit more into the gender pay gap. Like Shamali said, we haven't made any progress in the past 20 years in terms of closing that gap. So for every dollar white man makes, a white woman makes about 82 cents, and black woman makes about 66 cents, based on the research. And that really trickles down in the pandemic that we've just been going through, and in many ways are still struggling through. During the pandemic, a lot of American workers left the workplace, and unsurprisingly, more women left the workplace than men, and in fact, 4 times higher than the rate of men. So during the pandemic, 2 million American women left the workplace. The reason behind that is complex, and things that many of the panelists have been talking about, the childcare responsibility and the type of work, the quality of work that they're able to have. And women also have been coming back to the workplace at a slower pace comparing to men. In the workplace, there are also these policies affect the way that we make decisions in the workplace. For example, even when organizations provide parental leave and care, it can still be a struggle for women to take that leave because of what research has called the motherhood penalty. There is this fear of even when we take the opportunity to bond with the child and take that time to be a parent, there is a fear of being seen as less competent. There's the worry of being seen as less valuable or deserving compensation. And when we're looking at our female leaders, many of us in this room, women and women of color, we work in spaces that do not behave the way that we naturally are or speak the language that we speak. So we have a lot to do to swim up against the stream in terms of occupying leadership positions. And research also shows, unfortunately, there is this theory called role congruence theory, which means when we think about the role of a leader, we think about a traditional man. We think about assertiveness, persuasion, rationality, logic, which are all great traits, but not associated with traditional femininity. So femininity such as caring, empathy, democratic leadership skills that have been shown to be very effective, if not more, comparing to the traditional leadership styles. But women leaders are coming up against stereotypes and backlash from within and outside of their own organization. They receive less support from their subordinates and employees. And when women leaders step into an organization, a lot of times to be in a crisis position. So this is what research called kind of the women's cliff. When an organization is in crisis, they typically put a woman in charge to save the situation. However, we see contradictory evidence when women leader, for example, become the CEO of the company, the stock prices go down. The public has less confidence in a female leader. So just at all different levels, the role that we play in the workplace is really an upstream battle, and also connecting back to the social teaching and construction. We also play a role at home that is caretaking, put others' needs first, and take on that emotional labor. So all of that takes a mental toll. I think that's something that research in mental health is trying to understand and elucidate more in terms of these are not just a weight that we carry that doesn't mean anything, even though those weights are invisible. It does have a health outcome. For example, there's a line of research that talks about racial trauma that has documented how racism affects the way that we, people of color, experience their environment, that results in symptoms that's similar to PTSD. You think about hypervigilance, you think about flashbacks and worry and that tension, and all of that affect heart health among other health factors. And similarly, for women who are in the experience of oppression and holding multiple roles, being organized and under stress, and sometimes doing many people's jobs, that all has a severe impact on us. And we're just using research to delineate that, how there is a very tangible and specific impact on us.
Thank you so much. And this has been just a great panel discussion. I've been so excited to like snap and being able to ask questions of these great leaders. And now is the exciting time of the symposium where we get to hear from the audience and really be able to understand some of the questions that you have for all these great leaders and experts. So I'd love to get some additional questions for these panelists. We have one in the back.
So I'd like to ask the five of you, any of you grow up in Chicago? Did you go to CPS schools? So I've been a plaintiff. I'm an alum of Roosevelt, and I've been a plaintiff in 2 Title IX cases. And I would tell you that based on what I know about the health of women in the city, that the lack of sports opportunities for female students of CPS has had a direct impact on the poor health of city residents going back to 1972 when the law, Title IX, was passed by Congress. And I would encourage you to research this for your own purposes to help make especially minority women healthier.
Thank you for that point. Does anyone on the panel have additional comments to his?
I think I would just point out that that just extends further. Like, so we start thinking about it in terms of elementary school and kind of like moving along, but then we just saw the U.S. women's soccer teams, right, have to fight to get paid equally to what men's teams were getting paid, even though the women were outperforming the men's team. So I think, you know, when we're talking about connections, we have to think about it kind of through the lifetime. These are not isolated. The fact that one's in the school system and the other is in professional sports, there is a connection between the two.
We could see that also with additional conversations in the tennis world as well. Serena advocated that she wasn't getting paid the same amount for the same amount of hard work and all the medals that she was getting. So thank you for raising that. Are there additional questions? I see one here.
Hi. So my passion is community health nursing, and I'm trying to pursue that further. Something that Dr. Lee said that stuck out to me was the POC, person of color experience. They see their environment as PTSD, and I personally see that in my mom because she's an immigrant from Mexico. She came over when she was 15, and I was just wondering, like, how would you suggest as her daughter and as a nurse myself that I can help combat that in my mom, you know?
Thank you for that. I'm so delighted that you're pursuing the profession in healthcare and helping others. That's exactly what we need in our society. And I think you raise a really important and difficult question. I can expand on a little bit of that. Racial trauma or gender-based trauma, it works in a similar way as PTSD in terms of the symptoms that we may be thinking of as someone being traumatized. However, PTSD traditionally is thought of as one single event situation or multiple pronounced event that is very specific. You're thinking about assault, you're thinking about accidents and things like that. However, as we know, the experience of oppression is not a single event or any event that is any one or dozen events that's very specific. The researcher that does a lot on it is Dr. Camas Diaz. She's a psychologist, and she talks about the experience of racial trauma of being cradled to birth from the beginning of our life to the time that we die. It's a situation of complex trauma because it keeps happening. It happens at different levels and different places. So I think that really posed a tremendous challenge in terms of the aspect of healing because one, complex trauma, we don't have really good still understanding even to define it or the treatment to support it. And two, we know that trauma get passed down. There is the sense of generational and historic trauma. And trauma not only gets passed down through parenting, through community and family, but also it tags our genes. I'm not a neurologist, but there is, as I know, neurological study that found that through epigenetics, trauma genes gets passed down just as many other health outcomes gets passed down in our body to our offsprings as well. So in terms of healing, I think that is a big question. It just as the question of how do we eradicate racism and sexism and heterosexism, these big questions, it needs multi-level engagement. First of all, I think we shouldn't blame the victim. We should look at the system, acknowledge the history, and look at policy and the larger systemic issues and make them accountable and make work in those areas. And I also support the idea of our healing really should happen in community. Even though I'm in mental health, traditionally it's one-on-one, a very private healing space, but I think that really represents a Eurocentric bias as well. Healing doesn't only happen in private setting and one-on-one through a paid professional, although that's very helpful, very supportive of that. But we have so many communities, the global majority are in collectivistic cultures. So I think you're thinking in the exactly right direction in terms of how to be supportive of my family members and how to bring compassion. One thing concrete I will say is that trauma works through its own ways. So we see people experience long-term complex trauma, not really wanting to talk about it. They're closed off, right? They want to have distance, and we would even say dissociation from that experience. And that is something we need to bring compassion about because of how traumatizing the event is. overflows our capacity to deal with it. So it's actually a very functional coping mechanism to dissociate ourselves from the trauma event. So I think respecting the person who has those experiences, go with their pace, letting them know that we can be there to talk about it or give them resources when they are ready. But when they don't want to talk about it, and or using whatever way, maybe it's religion, maybe it's food, maybe it's community work, whatever ways that they feel like they can channel that healing energy, that's their healing can happen in very multiple channels. I hope that helps.
This question for Dr. Benjamins. Hi, how are you? It's been a while. Good to see you. You know, earlier during your introductions, you said that there were some cities that have a less of a gap between the health disparities. Which cities are those, and what are they doing differently? Is there anything that we can learn from them?
Yeah, thanks. It's good to see you. So we looked at the 30 biggest cities in the U.S., and part of this, it stemmed from that breast cancer study that I mentioned. When we found this giant gap in Chicago, our first thought was, one, it had changed over time. So two, we were thinking, what's happening over time? And then, is this happening in every other big city? So we first went to New York, and then we started looking at LA and some other cities, and we found, in fact, it's not happening at the same time or even across all cities. So that was kind of the impetus of this whole line of work. So we had a book come out in this past year called Unequal Cities, and it kind of maps out across all causes of death, across life expectancy, the 10 leading causes of death, some other causes that are either changing or have really big disparities. So things like HIV, opioids, homicide. So when we looked at those, we were looking for patterns. So are there certain cities that are doing really well? We found there are some, but it's really nuanced. There's no easy answer. So like El Paso, there's no difference between the black and white life expectancy. And actually right now at the latest data points, the black life expectancy is longer than the white life expectancy. So one, I really like this data because I teach medical students, and I get a lot of questions still of, it's genetics, right? There's something, it's biological. And this is very clear, like that's not how biology works. That's not how evolution works. You wouldn't have a gap here and a reverse gap over there. So the data is very telling. But there are some cities like Boston, Jacksonville, they're doing well. There's a much smaller gap. And then there's cities that are crazy big gaps. Washington, D.C. is like the worst in almost every outcome. San Francisco is near the worst. So we look at a few things. One, who has the best life expectancy overall? San Francisco. But the gap is really big there. So it really points your health community, your public health community, you need to address one specific subpopulation there. Other cities, there's less of a gap, like say Detroit, but that's because the white life expectancy is really poor in Detroit. So they need to rise the whole boat, right? They need to work on everything. But some groups need to focus money, policies, resources to different parts of their population. So it differs a little by outcome, but some cities are very progressive. Chicago, this has come out, Illinois. Our policies about health equity are amazing, but we have a giant gap, and that's because it's life course. It's something that comes up a lot. You can't just, turn your life expectancy because you have these very progressive policies about equity. So it's difficult because it's history. It's over hundreds of years. It's racial segregation. It's things that health people can't fix on their own. It's going to take kind of all the fields.
Hi. So it was touched on earlier about how research into diseases that affect women is underfunded. And I was wondering if you can talk a little bit more about that. Especially, it seems like there's just a lot of health problems that women run into, and we have very little options for treatment. And what does it look like right now? Is it getting better in the research world? What needs to be done still?
I can start unless somebody wants to jump in. I know I mentioned it. This is not my main area of research or focus, so I don't know too much about it, but I do know there's things like pain that we talked about that that's been attributed to psychosis among women, and it's thought of as psychosomatic, so like it's all in our heads. So things like that are underfunded because of the traditional kind of male hierarchy and what they think is important. So things like chronic fatigue syndrome might fall in that category. It's really interesting if you look and line up kind of the percent of mortality or morbidity versus the percent of funding NIH gives, and kind of line everybody up. It should be on one line, right? The things like heart disease, number one killer, should get the most funding, you would think. That's not how it works. There's studies up and down, above and below the line. So it's a little random because some get a lot of attention. So breast cancer, for example, gets way more funding than it should by the mortality and morbidity. But other diseases, lung cancer, I think, is one that gets way less. So it's not a perfect relationship, but a lot of it comes from kind of the historical understanding of health and biases against women.
I would say, too, marketing plays a big role in terms of the breast cancer awareness versus the lung cancer awareness. So I work at the National Institute of Health, and only really within the last 10 years, there was an institute that was created called the Office of Research on Women's Health. And so that's one of the newer institutes of the many that we have at the NIH. And even still, there's a disparity in how much research and funding goes to women's health issues. So it's not great, it's gotten better, but needs to get 10 times better, and that's why we're here for a Women's Health Equity Summit. So there are more discussions now than there were a decade ago, and there needs to be continued more discussions and more action around those discussions. So not just talk, 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 talk. I think we had an additional question over here as well.
I'm lucky I get the last question. So this may seem like a leading question, and maybe it's on purpose, but I just read something in The Nation magazine maybe last week that suggested that one of the problems in the US is the leadership in the medical field by MDs who focus on individual patients and individual health rather than systems. And so we end up spending most of our time looking at individual people and why you're the problem, rather than looking like, I think the suggestion was, well, why don't we have head of public health for the US government should probably be an anthropologist or for real, right? That would change the way in which we think about the underlying causes of health disparities and issues that we have, as opposed to looking at individuals and their actions and pointing fingers at them. And I want to ask the question, like, what do you all think? But the panel itself almost answers that. But I still want to know what people think about that. I mean, I don't think that thing is pointing fingers at what MDs do, right? Because individual health matters, right? No, I know, right? But it really is thinking more about, the entire panel's been about systems and systemic issues, as opposed to talking about individuals. And of course, we all have our individual thing to do. But the bigger part is the way in which we either get lucky, born into particular places or spaces as particular genders or races, right? So there's my sort of question.
I can weigh in. I can actually weigh in on a question. So I work at the National Institutes of Health. In the whole time period of the National Institutes of Health, all the directors have been male. There have been 2 acting female directors. Well, Director Healy, she actually served a very short time, so actually she was a director at the NIH. But for the predominance of directors of the National Institutes of Health, and this is the premier government organization that is able to provide funding for all types of research, has always been a male, and predominantly has been a male with an MD. There currently is no director of the NIH that has been instated from policy and politics of right now. So Francis Collins was the former NIH director. We have an acting director, Larry Tabak, but he's acting in that capacity, another white male. So I'm saying that all in the context of what's the definition of insanity? If we keep doing the same thing over and over, how do we expect to see change? And so that's true. How do we expect to see either a global change or personalized medicine? There's been more of a push towards personalized medicine. How do we do that if we keep instating the same type of people? So in order to be an NIH director, you have to be nominated and appointed in the government setting as well as from the President of the United States. So it just happens to be that all the presidents of the United States have predominantly been white males. And so how do you then change over this NIH entity that then gives out money to all these different institutes? I agree with you. There is a change that needs to come. And we do need to think about it with a totally different lens. However, the people who are currently in power and control are looking like the same people that get placed in the leadership roles for NIH and other organizations like that. So it's great that you have this difference of thought, but it's not global. And so again, we need to continue to have more conversations so that we can have more action around these conversations.
Yeah, I can chip in a little bit as well. I think that's such a great point, and I want to join the accountability and acknowledgement. And I would say not only the MDs, right, the psychology, the mental health field as well. I think we're just having an awakening of traditional, we think about psychoanalysis or talk therapy, people on a couch. I think very few people do that anymore nowadays, but there was this tradition of healing happens on this individual, and we look at what goes on in your mind that is not working. And now we are realizing there's so much more than that. What about family? What about society? What about policies? And all of that affects the way we think about ourselves, affect the stress and emotions that we feel on a daily basis, and that manifest as mental health symptoms. So I think we, as mental health professionals, have a long way to go as well, acknowledging kind of what makes us struggle with mental health and emotional issues. So I'm really kind of feeling hopeful that I'm teaching a lot of our masters and PsyD students at Roosevelt. They're very diverse and very systems conscious, and we're having these conversations all the time in terms of thinking about gender-based trauma, racial trauma, and all the policies and news that we hear every day. How does that affect the way we live? And also a note on kind of collaboration of health professionals among each other. I have colleagues and friends who are psychologists. We perhaps get more thinking around the social determinants and how do we provide multiculturally sensitive care in a therapy lens. But my understanding, please correct me if I'm wrong, I feel like that may have not been an emphasis in medical school. So I have a lot of psychologist friends who are hired as consultants in medical school to kind of talk with medical students in terms of when you are looking at the medical facts and the knowledge and all the things, the skills that you need, but in terms of providing care and building that caring relationship with the patient, how do you talk with someone who has a body size that doesn't fit the traditional medical model, so we don't perpetuate body shaming or fat phobia, for example, for women? And how do we make sure we attend to women of color's care and pay attention to areas that there may be vulnerability, but not making sure not to put the blame on them or the responsibility on them to say, I think, Maureen, you were talking about that systemic change is more important than blaming or kind of only working on the individual. So I would love to see more collaboration among healthcare professionals.
I mean, what's great is we're hoping this is the start of a conversation, and I'll share a little more about what's coming next, but I just first want to thank our wonderful panelist and moderator, and just let everyone thank them. Really appreciate just joining us today. And what we'd like to do, so as I shared at the beginning, I'm Julia Brady, working at the Roosevelt team. We hope that you've enjoyed the panel, and we also, there's a lot that was covered and obviously some things we didn't get to, and that's part of the reason we wanted to set some time aside now at your tables. We have the table hosts, as President Melixade mentioned, for just some follow-up conversation and kind of talk about, what you've heard, kind of share your own stories, and also share some ideas as well. I mean, a few things that really stuck out to me was, the role, the emotional and mental labor, like the other things that are impacting our health, just even, how much, in some cases it's about survival. So depending where we're coming from, here I'm thinking about, can I get in at a, convenient time for a mammogram? Whereas there's other people, can I get one, period? And is it going to be the right quality? And just learning how that's continuing to evolve. I think there were some great, just some perspective shared. And one of the things that we'd like to, everyone to talk about is ways that you can also support, and continue the conversation, drive change, do those things. So I also want to sort of point out that in front of each of you should be the book, Jane Against the World, and we have inside it, so take a copy home. We're having a virtual book read conversation in late April, and we hope you can join us for that. We also do have, so we're gonna have the formal reception, official reception in about 45 minutes, but if anyone wants to grab a quick refreshment, where you saw we had the iced tea, water, snacks, men's restroom right there. Women's is on the other side of Feynman Lounge, but if you want to take a couple of minutes and then let's come back here and we'll spend about 30 minutes or so with follow-up conversation. So thank you.
Well done, well done, well done, well done. Wow.